everyone, this is Vaishnavi Raut. My topic is second line antitubercular drug. Second line antitubercular drug are less effective, less well tolerated anti-TB drug and used only in case of the bacilli which are resistant to the first line drug. Let's see the classification of the second line drug. Includes the first fluoroquinolones, other oral drug and injectable drugs. In the fluoroquinolones, ofloxacin, levofloxacin, moxifloxacin, ciprofloxacin are included, and in the other oral drug, ethionamide, prothionamide, cycloserine, terizidone, para-aminosalicylic acid, rifabutin, thioacetazone are included. In the injectable drugs, kanamycin, amikacin and capreomycin are included. Let's see one by one drug. First one is the kanamycin and amikamycin are the aminoglycoside antibiotics similar to the streptomycin in antitubercular activity, pharmacokinetics and types of adverse effect. Adverse effect are the vestibular toxicity, hearing loss and the nephrotoxicity. Second one is the capreomycin, which is the cyclic peptide antibiotic which is chemically different from the aminoglycoside but with similar mycobactericidal activity, ototoxicity and the nephrotoxicity. Causes the eosinophilia, rash, fever and injection site pain, has to injected intramuscular and used only alternative to the aminoglycoside antibiotics. Third one is the fluoroquinolones are active against MAC. Moxifloxacin is most active fluoroquinolones against the M. tuberculosis. Mechanism of action: they penetrate the cells and kill the mycobacteria lodged macrophages and are the primary indication for the treatment of the drug resistant TB. Fourth one is the ethionamide, which act on the both intra and the extracellular bacilli. Mechanism of action: it converted into the active intermediate which interfere with the mycolic acid synthesis and completely metabolized in the liver. Has short half-life of the 2 to 3 hours. Adverse effects are the anorexia, nausea, vomiting, salivation, metallic taste, rash, peripheral neuritis, impotence, epigastric discomfort. Fifth one is the cycloserine, which is the analog of D-alanine. Mechanism of action: inhibit the bacterial cell wall synthesis by inactivating the enzymes which racemize the L-alanine and link to D-alanine residue, which is the tuberculostatic drug. Adverse effects are the neurological symptom includes the tremor, headache, slurring of the speech, psychosis, depression, altered behavior. Sixth one is the para-aminosalicylic acid, which is also the tuberculostatic drug and structurally similar to the sulfonamide. Mechanism of action: it inhibits the folate synthase enzyme and inhibit the formation of the tetrahydrofolic acid, which is necessary for the growth and multiplication of the bacteria, which are rapidly absorbed after the oral administration and poorly penetrate the blood-brain barrier. It metabolized in the liver by acetylation and excreted in the urine. Inhibit the acetylation of the isoniazide, which is the result drug for the management of the multi-drug resistant TB. Adverse effect: GI disturbance, anorexia, vomiting, abdominal discomfort, other skin rash. Sixth drug is the rifabutin, which is derivative of the rifampin, which is preferred over the rifampin for the treatment of the TB in the HIV infected patient, which is less potent inducer used for the treatment of the MAC infection in combination with the clarithromycin and ethambutol. Rifampicin is an analog of the rifampin but which is the potent enzyme inducer. Last drug is the bedaquiline, which is the diaryl quinolone, which inhibit the ATP production in the mycobacteria by inhibiting the ATP synthase. It is bactericidal and indicated for the treatment of the multi-drug resistant TB in combination with other drug. Adverse effect are the hepatotoxicity, prolongation of the QT interval. Let's start the treatment of the tuberculosis. The WHO recommends the goal for the antitubercular therapy, which are given in this PPT, in this slide, sir. And general principle of the antitubercular chemotherapy are use of combination of one or more drug and single dose of all the first line antitubercular preferred dots recommended by the WHO. Let's start the short course of the chemotherapy. The treatment in the dots given in two phases. First one is the initial intensive phase and second one is the continuation phase. In the initial intensive phase with the 4 to 5 drugs are used and lasting for the 2 to 3 months, aim to kill the bacilli, bringing about sputum conversion and afford the fast symptomatic relief. Second one is the continuation phase, which includes the 2 to 3 drugs lasting for the 4 to 5 months, during which the remaining bacilli are eliminated so that relapse doesn't occur. Here the treatment of regimen for the tuberculosis is given in this chart. In these two type of our patient are included. First one is the new patient, those TB patient who have either never taken anti-TB drug or taken them for less than 1 month, and second one is the previously treated cases, those TB patient who have taken anti-TB drug for the 1 month or more. They include the treatment of the recurrent TB. And let's see the treatment for the new patient, that is category 1 patient. Initial treatment with 4 drug HRZD include 3 bactericidal drug which decrease the risk of selecting resistant bacilli, and only after the intensive phase when few bacilli are left, only 2 highly effective cidal drugs in the continuation phase are enough to effect cure. Extension of the intensive phase beyond 2 months is not recommended now. The frequency of dosing during the intensive phase or the continuation phase or both can be daily or thrice weekly given. Daily treatment during both phases is considered optimal. However, keeping in the view the constant in organizing daily supervision of drug administration and to decrease the drug cost, thrice weekly therapy is acceptable in the continuation phase, provided each dose is supervised. If the constants are still pressing, even the intensive phase could be thrice weekly, but then HIV co-infection or the possibility of contacting it during therapy to be ruled out. Then the treatment for the previously treated patient, that is category 2 patient. The option of the if the risk of multi-drug resistant TB in particular patient is assessed as low or medium, a regimen containing a first line drug is prescribed. In the intensive phase HRZDS, total 5 drugs are given daily for the 2 month, and HRZD 4 drugs for another month. This is followed by the continuation phase of the 3 drugs HRE for the next 5 months. This 8-month empirical regimen should not be augmented by an injectable second line drug or fluoroquinolone, because this may compromise efficacy of this drug. The treatment regimen should be modified as and when the result of DSD becomes available. Retreatment patient whose multi-drug resistant TB's risk is assessed as high should be started on an empirical or standardized multi-drug resistant TB regimen, which is formulated by each country according to its local surveillance data and other factors. These patients are treated as presumed multi-drug resistant cases till DST result become available. Thank you. First one is the injectable second line anti-TB drug. Options are the moxifloxacin, B is the thiacetazone, C is the rifabutin, and D is the kanamycin. Answer is the D, kanamycin. Second MCQ is the which among the following causes QT prolongation? A is the rifabutin, B thiacetazone, C betaquiline, D is the cycloserine. Answer is the C option, betaquiline. Third, which of the following drug causes hypothyroidism? A is the amikacin, B para-aminosalicylic acid, C thiacetazone, D cycloserine. Answer is the B para-aminosalicylic acid. Fourth, anti-TB drug never given in the HIV patient. A capreomycin, B thiacetazone, C cycloserine, D rifabutin. Answer is the B thiacetazone. Fifth, last MCQ, for how many duration anti-TB treatment should be given in previously treated patient given in the intensive phase? A is the 1 month, B 2 month, C 4 month, D 5 month. Answer A, 1 month.